Today we begin second lecture. We begin a lot of local topics, and first of all we'll start from lung cancer. Today's topic, lung cancer. Lung cancer takes first place among all malignancies in humans. In males, first in males, second in females. Totally first. Due to what? First of all, due to smoking. And recent years it elevates with every year due to increase of smokers among females, first of all. Because previously, 20 years ago, lung cancer took 6th-7th place among females. Now second due to smoking. Elevation of smokers among females. Incidence of lung cancer first. Mortality due to lung cancer also first. And this is malignancy number 1 in all the world. Some words about etiology of lung cancer. Of course, first is smoking. Most danger, smoking of cigarettes. Some terms. Smokers may be active, which smoke cigarettes, first of all. And smokers may be passive, which breathe in this smoke. And these are friends of smokers, wives of smokers, people which are near the smokers. Smoking, active, passive. Active, passive. Additionally, about smoking, volume of smoking we estimate in pack years. Pack years. 1 pack year, it means smoker smokes 1 pack per day during a year. It is 1 pack year. 30 pack years volume of smoking. 20 pack years. Incidence of lung cancer in 30 times higher risk of lung cancer than in non-smokers. 20 pack years maybe during 20 years when smoker smokes every day 1 pack, but maybe during 10 years when smoker smokes 2 packs per day during 10 years. It is also 20 pack years. You see, if 2 packs per day, 20 pack years may be reached during 10 years only. If 1 pack per day, 20 years. But 20 pack years, highest risk of lung cancer. After 20 pack years, smokers can continue smoking and risk is the same, plateau of risk. Additionally about smoking, of course this is chemical carcinogenesis, it's a harmful habit of our humanity. Of course chemical first of all. On the pack of cigarette is written contains of nicotine, due to which smokers smoke drug. And tag, this is accumulation of all chemical substances in a cigarette. There are a lot of carcinogens inside. And tag, this is contains of tag. This is level of risk of development of malignancies because it contains of chemical carcinogens. Chemical tag. Additionally, tobacco, physical, right here, physical. Tobacco plant from which we produce cigarettes. tobacco can accumulate radioactive polonium from the if. And you see here is double action simultaneously with chemical action on the bronchial epithelium, maybe irradiation by radioactive polonium of tobacco, double action. That's why so high incidence of lung cancer, due to not only chemical action and due to physical also. And last, about cigarette. You know, cigarette consists of filter and cigarette. If smoker smokes all the cigarette, risk is highest. If to left 1/3 part, risk is much lower. If smoker cannot stop smoking, better to not smoke all the cigarette, left 1/3 part, and you can decrease your risk of lung cancer development. Enough about smoking. Next, chronic obstructive lung diseases. Chronic obstructive lung diseases. First of all, chronic bronchitis. Next, special chemical substances, asbestos. First of all. Next, TB. TB infection. Previously, maybe 15 years ago, we thought that if patient has TB, no cancer may be in patient. Now we know that a lot of malignancies may be simultaneously with TB. And TB, one of etiologic factors of lung cancer, we know it now. Next, genetic. We know that lung cancer more frequent in patients with previously treated from malignancies, or if patient has close relatives with malignancies also. These are genetic factors. Next, age. More than 45 years. Males have higher risk of lung cancer development. Next, pollution, of course. Pollution. A lot of manufacturers, and in big cities, air is very, very dirty, and due to pollution also maybe development of lung cancer. No. Next, classifications of lung cancer. We have two classifications of lung cancer. Of course, sure, first is TNM, international classification. And now here is local TNM classification for lung cancer. Before I'll tell you about TNM classification of lung cancer, I'll tell you now clinical classification of lung cancer. Okay. Clinical. Anatomical. Clinical anatomical classification of lung cancer. There are three groups. Central, peripheral, and atypical. Central forms. All lung cancer except only one form, bronchoalveolar, all they are developing from bronchial epithelium, from bronchuses, from bronchial epithelium. Tumors of lungs which are developing from main bronchuses, which central, this is main, lobular, segmental, and subsegmental. All this is central lung cancer. Peripheral, all tumors which are developing from lesser to bronchuses, lesser than subsegmental. There are approximately 21-23 divisions from main bronchus till alveolus of bronchuses. 4 first, this is central. All others, this is peripheral. And it doesn't mean that central in the central, peripheral on the peripheral of the lung. It's not correct. Only it depends on the bronchuses. Lesser than this. Central forms may be exobronchial, peribronchial, and tree-like form. Tree-like, like tree. Exobronchial when tumor grows in the cavity of bronchus. Peribronchial when tumor grows along the wall of bronchuses in the lung. And tree-like form, this is combination of second and first form. It grows from periphery to the center and it looks during bronchoscopy like branches of the tree. These are 3 forms of central lung cancer. Peripheral forms. On round tumor, pneumonia-like, pneumonia-like or broncho alveolar cancer. Round tumor, sometimes we reveal lung cancer without any signs. On the chest X-ray, ordinary chest X-ray. And here is, it looks like round tumor in the lung. And this is one of the forms of peripheral lung cancer. Round tumor may be primary tumor of the lung, maybe metastasis to the lung from another origination. But this is one of the forms of peripheral lung cancer. Round tumor, only without any signs. It looks like round tumor on the X-ray. Pneumonia-like form. This is very separate form of lung cancer. I told you it develops from alveoles. It looks like pneumonia of the whole lobe of the lung, maybe 2 lobes of the lung. Signs of this tumor: a lot of sputum, 2 liters per day, even more maybe. And if you do cytology of the sputum, you find a lot of malignant cells in the sputum. Tumor consists of parenchyma and stroma. Parenchyma, nerves, dead cells, connective tissue, parenchyma, cancer cells. Stroma, this is skeleton of tumor, consists of nerves, dead cells, connective tissues. Here is, in case of pneumonia-like cancer, lung cancer, tumor doesn't have parenchyma, skeleton. Tumor cells only in the sputum of the lung, nourishing through the sputum, and no tumor. Only a lot of sputum inside with malignant cells. What's characteristic for this form? Fast spreading in the lungs, bad prognosis, and resistance practically to all types of treatment. Pneumonia-like form. Pneumonia-like form. Pancreas cancer. Pancreas cancer. Cancer of the apex of the lung. Cancer with bright manifestation. At the apex of the lung, upper aperture of the thorax. Tumor can invade first, second, and third rib, clavicular. Due to this invasion of the bones, may be severe pain. Next, invasion of subclavian vein. Here is at the apex of the lung. Edema of upper extremity, second sign. Next, invasion of the nerves of plexus brachialis. Some abnormalities in sensitivity or mobility of upper extremity. Invasion of ganglion stellatum. Ganglion stellatum, this is apex of two sympathetic trunks along vertebral column. Apex of them, this is ganglion stellatum. It innervates eye. Maybe ptosis, meiosis, and ophthalmia. Gorner's syndrome. 4 signs. Here is Gorner's syndrome. Abnormalities with nerves of upper extremity, edema of upper extremity due to vein compression or invasion, and severe pain due to invasion into the bones. Pancreas cancer. And last one, cavitary form. Cavitary form. Cavitary form. On the X-ray, first of all, when you see cavity with level of liquid, you think about chronic abscess or acute abscess of the lung. But in case of cancer, also may be level of liquid. But walls here is thin in case of chronic abscess, walls thin and smooth. Here is walls thick and not smooth. This is first sign on X-ray. Second, how to prove? Of course, in both cases, a lot of sputum with pus. But in case of lung cancer, when you do cytological examination of the sputum, you reveal malignant cells. Here is also cytological examination of sputum. 4 peripheral forms: round tumor, pneumonia-like form, pancreas cancer, and cavitary form. Atypical forms. Sometimes we cannot reveal primary tumor in lung. This is T0 form. We cannot reveal, very small, but we find metastasis. What typical forms for lung cancer? Mediastinal. We cannot reveal primary tumor in lung, it's very small, but we reveal metastasis into mediastinal lymph nodes. Miliary carcinosis. On X-ray or CT, you see a lot of small round tumors in the lungs. And you cannot tell where is primary tumor, where are metastases of this primary tumor into the lungs, from the lungs to the lungs. And this is miliary carcinosis, also a typical form of lung cancer. Also maybe liver form, cerebral form, when you cannot find primary tumor in the lungs, but prevails the manifestation of metastasis. This is clinical anatomical classification. Now, TNM. Why I told you about clinical anatomical classification before TNM? Because T, primary tumor classification, differ from 4 peripheral and central forms. Let's start about T. TNM. Now begin from T letter. First, let's speak for peripheral forms. Peripheral. More simple. Peripheral forms. It depends on size. T, maybe 0, I told you, when we cannot find primary tumor, but we find metastasis into mediastinal lymph nodes or distant metastasis, T0. Tx, when we cannot establish real spreading of tumor to the vessels, to their adjacent structures, on the base of examinations which we have in our hospital. For example, we don't have PET-CT or we don't have MRI or CT. We have only a chest X-ray. On the chest X-ray base, you can only estimate size of tumor, for example. That's all. If you have CT, you can do every T. But TX in some cases, when you cannot really reveal spreading of tumor. T1, for peripheral forms, tumor less than 2 centimeters. T2, tumor between 2 and 5 centimeters. T3, more than 5 centimeters. And T4, invasion of adjacent structures. For example, pericardium, diaphragm, vessels in mediastinum. This is T4. This is for peripheral. Now for central forms. Central forms. And we need to draw bronchial tree. Okay. Trachea. Left bronchus. Here is carina of trachea, bifurcation, beginning of bifurcation. Right main bronchus. In the left lung, you know that only two bronchuses for upper and lower lobe. In left, in right, upper intermediate bronchus, and then here is middle lobe bronchus and lower lobe bronchus. This is picture of bronchial tree of humans. Okay, for central lung cancers, do you remember? Central lung cancer, this is cancer of main bronchus, lobular, segmental and subsegmental. And here is tumors which are more distal than main bronchus. This is T1. All other tumors in main bronchuses. And here is, we need spatial distance, 2 centimeters from carina of trachea till tumor. If distance between tumor and carina of trachea more than 2 centimeters, this is T2. If tumor here, if tumor is closer than 2 centimeters to carina of trachea, here is. This is T3. T3 less than 2 centimeters from carina of trachea. And last one, T4. Tumor of which spread to opposite bronchus or trachea. This is T4. Spreading to the opposite bronchus through carina or spreading to trachea. This is T4. And this is T classification for central lung cancer. Here is for peripheral, depends on the size. Now about N classification. N0, we don't find metastasis into regional lymph nodes. N1, metastasis to the hilar lymph nodes. Hilar metastasis, hilar ipsilateral metastasis. N2, ipsilateral, the same side, ipsilateral, mediastinal. N3, contralateral mediastinal. Or supraclavicular. N3, sorry, N3. This is M classification for lung cancer. Metastasis to the regional lymph nodes. M, very simple. For lung cancer, like for all tumors, maybe 0 or M1. And now we need to speak about target organs which are most frequently affected by metastasis from lung cancer. M1, where lung cancer likes to give metastasis. First of all, also to the lungs. From the lung cancer to the lungs again. Next, bones. Brain. And kidneys, most frequent. Maybe everywhere, but these are most frequent organs. Enough about DNA classification. Signs, manifestation. Lung parenchyma doesn't have spatial sensitive nerves. What does it mean? If tumor is peripheral and doesn't invade pleura, because in pleura we have sensitive nerves, even in case of big size of tumor, maybe no signs. Usually peripheral lung cancer without signs. Peripheral without invasion, no signs usually, but only when invasion to adjacent structures, maybe signs. No, if tumor in parenchyma, maybe no signs. Even size of tumor maybe like 10 centimeters. Also, if with no invasion, patient doesn't complain. Doesn't have complaints. Peripheral, central forms. In case of central forms, and now you can ask me what percentage of peripheral and central forms. Central forms more frequent, 70% approximately. Here is 30%. Central forms. What signs may be? Cough. Cough may be dry or maybe with sputum. Sputum sometimes maybe with blood. We call it hemoptysis. Hemoptysis. Fever. When we speak about lung atelectasis, parabronchial pneumonia, paratumoral pneumonia, I'll explain you what about fever. Fever. Sometimes maybe anemia, not only due to direct intoxication of patient. Also maybe due to metastasis to the bone marrow. Also maybe anemia and bone marrow depression. Dyspnoea. Due to atelectasis of the whole lung, due to hydrothorax, total hydrothorax of the hemithorax, for example. You see here, no spatial signs of lung cancer. No signs when you can tell, oh yeah, this is lung cancer, exactly, no. Some signs looks like signs of TB, some signs like signs of chronic bronchitis or acute pneumonia. But to decide what is this, exactly this is lung cancer, you cannot. No spatial signs, only general signs. Okay, this is about signs. Now, let's speak about complications of lung cancer. Complications of lung cancer. First, superior vena cava syndrome. When tumor is big, it can compress mediastinum and superior vena cava also. When tumor gives metastasis into mediastinum and they are big, they can compress superior vena cava also. To compress aorta, it's impossible, very rare cases. What to compress? What's more simple to compress in mediastinum? Of course, vessels with soft walls. Of course, this is superior vena cava first of all. Superior vena cava, one of the biggest vessels of our body. It collects blood from head, neck, upper extremities, upper part of the body. That's why, due to superior vena cava syndrome, maybe enlargement of subcutaneous veins, because blood need to go to the heart from these regions. When? Where? Not through superior vena cava, in this case of compression, through collaterals and through inferior vena cava. That's like enlargement of these veins, collaterals, subcutaneous veins. Edema of the face, of the neck, and of the thorax, upper part of thorax. And this is very severe complication, superior vena cava syndrome. Here is, I told you about when I told about treatment of patients. We cannot start special treatment without morphological verification diagnosis. This is exclusion. Here is, this is very severe complication. Patient can die. That here is, we cannot wait till morphological verification, till diagnosis. We need to start immediately treatment of patient, chemotherapy or radiotherapy, to decompress superior vena cava syndrome or to operate him. Superior vena cava syndrome. Atelectasis. Atelectasis of the whole lung, for example. Atelectasis have 3 stages. Atelectasis is full obstruction of bronchus without breathing in the lung. Of course, lung is not, no breathing in lung because through full obstruction. Atelectasis of the whole lung. Next, hoarseness of voice. Hoarseness of voice. Hoarseness of voice may be due to invasion of laryngeal recurrent nerve. Left laryngeal recurrent, right laryngeal recurrent nerve returns to the neck from their supraclavicular region, and right laryngeal recurrent nerve usually is not affected. Usually this is left laryngeal recurrent nerve because it's going from the neck to the thorax and it's returning to the neck under the aortal arch. Here is in this window, aortal window, it may be invaded by primary tumor or by metastasis to this region, to the aortal arch, by lymph nodes in the aortal arch of mediastinum. Hoarseness of voice due to invasion of left laryngeal recurrent nerve. Bronchoesophageal fistula. Bronchoesophageal fistula. Sometimes tumor of bronchus can invade esophagus because they are near, and maybe destruction of the tumor and maybe formation of the canal between bronchuses and esophagus. Due to bronchoesophageal fistula, first of all, first sign, this is cough just after drinking of the liquids and just after eating. Next step, this is development of aspirational pneumonia, and in all cases this is lethal complication. Hydrothorax. Hydrothorax. Of course, this is collapse of the lung due to metastatic, usually metastatic hydrothorax, metastasis to the pleura, and excretion of a lot of liquid, malignant liquid to the thorax, and due to it collapse of the lung. Here is lung cannot breathe due to obstruction of central bronchuses. Here is due to collapse by compression by this liquid. Collapse due to compression by this liquid. Hydrothorax. Next. Bleeding. Bleeding. Bleeding from pulmonary artery can lead to the death during 3 seconds after the beginning, because this is a very big vessel and practically all blood of patient can discharge during some seconds after the beginning of these complications. Lesser vessels, of course, this is maybe from hemoptysis till severe bleeding How to try to treat it? First of all, not speak. Special hemostatics, cold on the thorax. Patient cannot move, he needs to be in the bed. This is bleeding, and in some cases even we cannot stop it medicamentously, only surgical treatment. Stop of bleeding, this is ligation of vessel, for example, or bronchoscopy with spatial manipulations. Diagnostics. Diagnostics of lung cancer. We begin, usually we review and we begin practically in all hospitals from chest X-ray. On chest X-ray we can only reveal tumor and estimate size of tumor, and this is enough. Only this we can do by X-ray. Some words about mediastinum, but it's difficult to differentiate where is mediastinal lymph nodes, where is aortal arch, a lot of questions. Next step, CT. Of course, CT with intravenous contrast, and not only thorax. Usually we do abdomen, pelvis, and for lung cancer, because I wrote and one maybe also brain. That's why not only three floors, classical three floors, pelvis, abdomen and thorax, and brain also, head also. CT. Next, PET CT. Also we use it for lung cancer, for revealing of very small metastasis somewhere, or after neoadjuvant treatment to estimate what the real regression of tumor. PET CT also useful here. Next, fiber bronchoscopy with biopsy. For central forms of lung cancer, we can use fiber bronchoscopy. We can see from inside bronchial tree, but only main lobular segmental subsegmental bronchuses. Deeper impossible by bronchoscope. For central lung cancers, we use fiber bronchoscopy for topical diagnostics, whereas tumor spreading of tumor from inside the bronchus, and for morphological verification. We can take biopsy primary from the tumor, directly from primary tumor. Fiber bronchoscopy. Next. Sometimes, in case of peripheral lung cancer, of course, it's very difficult to diagnose tumor morphologically. How can we verify diagnosis here? Transthoracic, fine needle aspiration. Transthoracic fine needle aspiration. Under the control of X-ray or CT, we can make biopsy, fine needle aspiration of tumor in the lung. Next. Fiber bronchoscopy with transbronchial biopsy, fine needle, of course, under the control usually of X-ray or CT. For peripheral tumors, sometimes we use this or this. Next. If patient is senile, contraindication for these examinations, for example, severe heart diseases or chronic severe lung diseases, and patient has a cough with sputum, we can collect the sputum for cytological examination. Cytology of sputum. Cytology of sputum. How much times? For example, first time we collected sputum from patient and we didn't reveal any malignant cells. 5 times. More or less, we need to repeat it 5 times. Sometimes patient, you can tell me lung cancer is inside the thorax, how to examine patient with palpation or something else, classical methods of diagnostics. I can answer sometimes maybe metastasis to supraclavicular lymph nodes, remember, and free. We can reveal them by palpation of supraclavicular region. You begin examination of patients with suspicious lung cancer from palpation of supraclavicular region of the neck. And you can reveal or exclude metastasis even clinically. Here is. And if you find enlarged lymph node in supraclavicular region in patient with suspicious to lung cancer diagnosis, you need to do fine needle aspiration or even incisional biopsy of these lymph nodes or excisional. And that's all about diagnostics. Now one more classification, which also the same for all the world. This is morphological classification of lung cancer. All lung cancer we divide into 2 groups. First, non-small cell lung cancer. Non-small cell lung cancer. It consists 95% of all cases. Second group, small cell lung cancer, only 5%. All what I told you before in this lecture, all this connected with non-small cell lung cancer. And when we speak about lung cancer, usually we think about non-small cell lung cancer, about this group. This group is very small, and this is even separate disease because in other classification, in other stages, in other survival of patients, and even in other tactics of treatment. Small cell lung cancer, etiology unknown, biological active cells. It growing from biologically active cells. Sometimes it may be hormone sensitive. Approximately 1/3 of patients hormone sensitive. And also in 30% of patients from the beginning of disease of patients have metastasis to the brain. In brain from the beginning. Only 2 stages for this cancer. Local, when tumor only in the thorax, and spreaded, when tumor is spreading outside the thorax. Because this is very fast growing tumor. Sensitive to chemotherapy because very fast growing. And radiotherapy. How to treat these patients? Of course, for general, it's chemotherapy, and for all patients with small cell lung cancer, we use radiotherapy of the brain. Even when we don't reveal metastasis to the brain, they may be very small. We radiate brain curies also for all patients with small cell lung cancer. Survival very bad, approximately maybe best survival 2-3 years for small cell lung cancer patients, and this is record even. For usually this is less than 1 year, small cell lung cancer, with bad prognosis and separate form. All which we spoke about, this is not about this. This is about this. This is classical lung cancer, non-small cell lung cancer. Here is maybe squamous cell lung cancer, adenocarcinoma, all other forms. This is non-small cell lung cancer. And we treat, here is all tactics of treatment developed for non-small cell lung cancer when we speak about lung cancer. Here is, I told you, chemotherapy, radiotherapy of brain. In some cases, in case of complete regression and localized stage, sometimes we use surgery. Non-small cell lung cancer. This is lung cancer. Treatment. What types of treatment do we use for lung cancer? Treatment. Maybe 15 years ago, we used classic chain of treatment for lung cancer: surgery, rule, I remember even rule about lung cancer surgery. If you can remove tumor from lungs, do it, and then do something else. Surgery, then chemotherapy, and last radiotherapy. This is past of treatment of lung cancer, because oncologic scientists took maybe 1 million cases of lung cancer patients, and they estimate effect of chemotherapy. This is adjuvant chemotherapy after surgery, and adjuvant radiotherapy all after surgery. Of adjuvant chemotherapy on the survival of patient. And they revealed that no effect on the survival of patient in lung cancer patients of chemotherapy in adjuvant regimen. Better to use it before. All regimens which used before in adjuvant regimen chemotherapy all had benefit of survival. That's why now chemotherapy is before, then surgery, and then radiotherapy. Radiotherapy is only one proved type of treatment which can prolong survival. Chemotherapy additionally can prolong survival in neoadjuvant regimen. This is modern chain of treatment of early stages of lung cancer. What types of surgery do we use? Minimal volume of surgery of oncopulmonary surgery. This is lobectomy. Segmentectomy, this is only for treatment of TB. Lobectomy, this is minimal volume of removal of lung parenchyma in case of peripheral tumor or central forms without metastasis to the hilar lymph nodes. Classical volumes, pulmonectomy or extended pulmonectomy. In all the world, here is a rule of surgery. This is removal of primary tumor, and in all cases we need to do ipsilateral removal of primary tumor plus ipsilateral mediastinal lymph node dissection, mediastinal dissection. This is rule. Ipsilateral mediastinal dissection in all cases, because previously we didn't use it. And now we know that even if we don't reveal metastasis to the mediastinal lymph nodes on the base of CT or PET-CT, and we remove this fat from mediastinum, in 20% of cases we can reveal metastasis there. That's why now we reveal to not miss this hidden metastasis to the lymph nodes, very small. That's why we use ipsilateral mediastinal dissection in all cases. This is the rule of pulmonary surgery. Two operations also may be extended. Here is not all operations extended in case of lung cancer, and combination with resection of invaded adjacent structures, pericardium, diaphragm, chest wall, everything maybe. Ribs. This is surgery. Chemotherapy. We know a lot of medical drugs, chemotherapeutic drugs, which are effective in case of chemotherapy. Now, squamous cell lung cancer and adenocarcinoma, these are different ways of use of chemotherapy regimens. Different. But it's not all. Now, we use also inhibitors of immune checkpoints for lung cancer, for adenocarcinoma and for squamous cell lung cancer also, non-squamous and squamous. These inhibitors of checkpoints, of course, in case of melanoma, special term. Okay, I'll tell you about PDL expression. PDL expression. In case of melanoma, we don't need PDL expression because we know that in all cases it will be effective. We even don't do this examination. But in case of lung cancer, now we do PDL expression because not in all cases it will be effective. And if PDL expression, old rule was more than 50%. We use inhibitors of immune checkpoints. Now we have a lot of trials, and then they estimate the effect of inhibitors of immune checkpoints in case of when PDL expression will be more than 1%. In case of zero PDL expression, of course, we don't use it because it's not effective. It's about PDL immune checkpoint inhibitors, immune therapy. Radiotherapy. When mediastinal lymph nodes are affected, of course, we remove them after chemotherapy. It's old chain cleaned. After pathological examination, when pathologist told you, okay, some lymph nodes were affected and it is N1 or N2, better for local control to irradiate mediastinum. Here is in affected regions only. And we do radiotherapy of zones of mediastinal lymph nodes metastasis. We do their radiation. It's about radiotherapy. Next question. Next question may be most difficult. Survival of patients with lung cancer. Lung cancer, most frequent tumor in humans. It takes first place in humans. And what about, let's take all patients with lung cancer. 30% of them. These are early stages which we can treat radically. 30% radical treatment. 70% late stages. Late stages. You understand? Late stages. This is the treatment is not effective practically in all cases in late stages of lung cancer. And 70% of primary diagnosed patients, even before treatment, we know that they will die very soon. Let's speak about this 30% for radical treatment. Of course, with the radical treatment. Okay, radical treatment. We treated them radically. This 1/3 of all lung cancer patients. And 5 years survival. 5-year survival. 5-year survival will be only in 30% of patients. 30%. You see, only 30% in early stages. 30% from these 30% after radical treatment can live 5 years. Overall, 5-year survival of lung cancer, 10%. Cancer number 1 in humans, mortality is very high. And even due to our modern treatment, it elevates but a little. And you understand that this is field of investigations of a lot of pharmacologic manufacturers, because lung cancer every year more than 1.5 million of patients, new patients every year with lung cancer in the world, and death of practically the same number of patients. This is tragedy, of course. Our second lecture is over. Next lecture will be about breast cancer.